is a night therapy night, and just follow through with that so that they know the time and what the plan is, sort of an agenda.
Okay. Anything else on A? B is a goal that we probably will keep in our marketing plan forever. We didn't think that we wanted to take that out, so talking about census projections and maintaining our fiscal responsibility at the same time.
I didn't jot that down, but I need you to evaluate 3 one more time here. Number 3, it isn't jotted down on your paper, it's on mine. Just reread that over to make sure that this is a feasible, obtainable goal. B3. Provide free evaluations and assessments to the community and obtain at least 2 admissions to the adult, 2 admissions to adolescent, 1 admission to AODA dual diagnosis, and 2 admissions to partial per month from this process. I need to know if those are feasible, obtainable, if that's way out, and that's one that we didn't evaluate last time. With the on-call system, I guess, Paul, you could address this a little.
We would admissions to the adult in the ADA.
Okay.
I would agree, it hasn't happened at all in a year. So,
okay, so that's not a feasible obtainable.
I don't think so. And what about trying for 1 to adolescent, 1 to partial? See if you make that.
Kind of in our dialogue even with Sandra this morning, that admission, free assessments and offering this and bringing community in and making them. I think that the consensus of our discussion was we need to advertise that more, that we do that, and the fact that we, haven't really, made that an issue. It might be why we're not getting those kinds of numbers. And so I still don't want to put it in here if you don't think it's a feasible, attainable goal. That is one of the directions that it seems the hospital wants to, us to kind of look at.
Last year.
So I just want to understand, I'm sorry to interrupt her, is Paul going to fulfill that accomplishment?
As he responded to it, sounds like he feels it could be in adult and AODA accomplished. Now, there's question on if it would be in partial, and there's question about adolescents.
What about if we would break this down differently and say at least 2 admissions to adults and 2 admissions to the dual diagnosis? And how about if we just made the other 2 because Christy, you said you hadn't had an admission because of it last year.
Right.
And I'm not sure about the adolescent and anything about the information on it, but how about just breaking it down into there will be 2 RDA contacts per month regarding the intake system, specifically with someone who could refer to the adolescent program.
Yeah, I'm thinking we need an objective in there somewhere different from these goals that says we will promote the service. And it needs to be something every time you make a contact, you have a new product to sell. And it's got the potential to really, really take off. So maybe a separate objective to promote the fact that we have free assessments, and then one to say this is what you're supposed to take. It's almost 2 things. So make it an RDA goal and also make it a census.
I think the RDA goals are covered elsewhere. I think they're covered elsewhere
with
and
the
very specific. This is the only place that I know that the pre-assessment, and I would respond to the adolescent. I think we could go back, and I think we have accomplished 1 from assessments because we have 91% came from marketing in adolescents, and most of them are phone calls, and Rafael has those
I think you
assessments.
can make one.
So I think that one is real solid.
And I think if you
I
guys
think-
work together.
Yeah, I think with the on-call system and the looking at, we might evaluate partial, in a different direction. So what I'm hearing is that we want to make sure that there's a response in RDAs on how many RDAs we're doing and everything else.
But not the general RDAs, but
Okay.
a focus on when we do RDAs, we have something new to talk about, and we will promote free assessment and referral,
Okay.
more customer
People
responsive.
specifically could refer adolescents for
Right.
the partial program.
Not that we'll necessarily make more contacts, you guys will make a lot of contacts, but just put in the plan that we have something to talk about, and it's potentially meets a need and can get us business.
Are you seeing that as an objective, or are you seeing that covered under some other topic later on in the
I think it
market
needs to jump out, and it didn't jump out to me, so I think if it's not here, it needs to be here. So we might need to add it. And you can put it anywhere. You put it under contacts. You can put it under the promotion, number C. It could fit in a lot of places.
Who is going to do the assessments?
Oh,
He is right now.
No, I mean, I was just questioning if there was going to be further assessment as far as medical or
Well, I think when
phone
we-
contact.
Yeah, just to be clear, when we're talking about free assessments, we're talking about all kinds of things we've done historically, which is basically, even though Paul will be doing most of the assessments, really, for adolescent program, for the partial program, maybe not appropriate for him to do the assessment, it may be appropriate for the assessment to go directly to Krista, one facilitator. Make a call, call Krista, say, we've got this person who wants to see partial. Krista certainly could assess the patient as referral to it, has done for the adolescent program. These are the people that know the programs, respond to questions, really appropriate people. So I can direct it to potential patient assessments.
If it's a patient you don't know on the phone conversation where they're going to fit in,
Yeah,
right.
you'd end up
Paul does a triage of these cases and just the appropriate.
Well, and I think that goes back to the solidifying of that type of information and communication with everyone, including the evening and night stay. Because, as you and I are well aware, this is where lots of issues have come up.
so they have to be informed more that Paul is available,
That is correct.
and that the whole on-call system is
That is correct, because we
Really
certainly have had periods whereby the staff have been barraged, and clearly those folks who have carried the beeper are aware of it on evenings and on nights.
I do want to get the message to our staff that this is designed to help you. It's designed to get you out of the loop real quick. It's designed to be a resource for you so you don't have to pass
Mhm.
45 minutes,
Mhm.
minutes fast, okay, good fast, everything else. And our challenge is to get all of our staff educated, including pool people.
And I could start to, I could have to even do it tonight, where I just pop in on the PM shift and activate some of an out of report. And just-
Yeah,
I think we should every night about 2 o'clock in the morning.
or change a shift at 11 o'clock at night.
We'll be here 4 hours a day, then, because we do a lot of.
I think
You
again
can
that
connect with our communities, right?
That's right.
I'm going to pull you all back to my objectives here.
I was going to say, I think that deserves to be in the subjective I envisioned about promoting this. There's that internal piece too. So maybe that objective of promoting the enhanced ability to handle assessment and referral has the internal contact as well as the external contact. Yeah, because if our own people don't understand how it works, when it works.
Okay, can we move on along then?
We are leaving 3. Can you clarify how we're leaving 3? Provide free evaluations and assessments to the community. We leaving it this way? Are we going to step in and stop it there? Or then going on with at least 2 admissions to adult, 2 admissions to adolescent?
Well, I thought we were going to stop it there and go on to be more specific. We need to quantify it here.
I need to
How many?
quantify it in objectives. At least I've been told objectives need to be quantified.
We talk about changing adolescent to 1. It's more
Mhm.
realistic.
And ours to 1.
Yeah,
Partial to
Yeah,
1.
which is more feasible with you,
Yeah.
Road. You're gonna have 2 to AODA though, right?
You're getting that now.
Yeah.
Okay.
So just change those to 1.
Yeah, well, that's the other area, I'm sorry. I don't, yeah, lesson program, no, partial program, that's very, assessments also.
For the AODA.
But
So I'm going to add another objective either to this area or someplace else that will talk about promoting and focusing the free evaluations both internally and externally, correct?
Yeah, we just need to set it up. That's
And then number 5. I looked these up. These are new numbers on here. Remember, it was suggested that I look up what is the average daily census and add 1 to it. For these as a goal here, I want you to see it in print to see if this build an average daily census by 1993, 5 to adolescent, 5 AODA, 20 adult, 7 partial, and 10 for special care programs. Those are all what as the average daily census at this point. So we're really, everybody's okay.
yeah, you can see. Continue to promote program awareness by activities extend beyond our target market area. Oh, I almost got away with our people. The C part here, we talked last week, even though this is a community hospital, and we're focusing on our local communities, our local zip codes, we are certainly interested in expanding the diameter, the radius of our target market.
Active and sign.
Yeah, Jerry Father, you have a blur. You have to change his whole lifestyle,
Okay, the gist of the C is to basically expand our expression horizons to beyond our 7 zip code. Lots about it.
As I'm writing this over, I'm also becoming aware of that goal. This is not only beyond our target market, this is also in our target market, that I'm not sure that, I should put, the wording, because it also, all of these activities are also those that would attract people right in our area. So either I'm going to have to put those in a different area or add more to that goal. The next time I'll play with those words.
You could just say within and beyond.
Within and beyond.
And that might be the place to put that we're going to promote assessment referral internally, externally, locally, regionally, nationally.
Worldly.
You know, they have those international awards now, you know.
Orally.
If you look at number 6, just a reminder. Number 6 is a general statement about programs through media. We develop and will develop a specific media plan. It's very specific about what kinds of media monies are spent on what. We do get more specific than this meeting.
Everybody heard Toby on the radio this morning?
No.
We never did find out if she's on again. I'm sorry, Toby, I never
What time?
called.
Where you at?
She was on around 6:25.
Yeah,
Talking about, what was your topic?
Stress management in the 90s. And what happened is, Kelly was supposed to do it yesterday, but she wasn't feeling well, so she asked me, if I could do it. I did. It really wasn't very good, because it was just 2-3 minutes.
You're much more cookie than I was yesterday. Thank you.
Okay, we wrapped up with C. Maybe we could,
Is this included the outpatient, enhancing the outpatient services?
I think this would be a good area to bring it in. When I looked over the big picture, realized that I haven't addressed that. It's a good suggestion. Also, one of the other things is the support groups, the local support groups, and that they wanted to expand upon those in the area. And this would be the other area to bring in that objective. Again, that was brought up by some of the interviews that I've taken. So I will
we're
have
talking
to
about
work on.
promoting our, developing clinical programs in the outpatient, that's like under E.
I think that is program development rather than
Okay.
promotion.
And when I think when we're talking about promoting our programs, that would include whatever programs we have. Can we take a break and I have something to eat and try to get through these last couple of objectives, because we'd like to put a little bit of time through the SWOT exercise. Is that all right? Some discussion about partial.
I was
Thoughts?
about the difference between
E and
You
F.
guys have talked about
Not necessarily, but Val brought up the fact that should we combine E and F? And do provide quality clinical programs, provide and enhance. Is that what we had said? To provide and enhance quality.
Wasn't the rationale last week just to separate it only to highlight the clinical
That's right.
portion?
We wanted to just zero into the clinical. That's exactly right.
But Val has a good point. It all comes
that's good.
to
I
the
just prefer to see them
Combined?
combined. Yeah.
Ongoing evaluation.
What is it?
Ongoing evaluation of clinical programs.
Yeah, that's right. That's right. We're talking about evaluation.
Being able to evaluate the programs.
So, where are we here?
I guess I need, if we're combining them, and I know that we haven't addressed some of the clinical issues anyplace else, then I need us to focus on some of the clinical objectives. Yeah, I'm still uncomfortable combining those.
Clear on what you are expecting for, if you want to continue using the statement to provide quality programs that meet community needs. Since our programs do meet the community needs, perhaps, I agree with Val to enhance the clinical program component would be perhaps to, on down the line, look at a multiple personality component to the clinical program. We talk about eating disorders. We don't really have that many or even focus on that as an issue clinically.
So our objective.
Is that what we're is that what we're looking for? That's what I'm trying to understand.
We're going to try and identify specialty services that we may provide in the future.
What you're talking about, when you have multiple personality, maybe you're talking about borderline personality?
The specifics,
Group of 85%.
the specifics like multiple personality
Only have to have
would
one
not
person in a
come
group.
here. The specifics like multiple personality would not come here in the objectives. We would say, then we would look at
That would
different
be
type of
allowable.
programming, developing specialty programming.
Such as.
And,
We'd say such as, and then maybe
Yeah,
list
and then
it.
Yes, make it a menu, don't commit to doing them all, but at least explore.
Exactly.
Because eating disorders, I don't think probably will not develop a specialty program for eating disorders,
No.
although we would have specialty services and the same thing perhaps.
Yeah, with your multiple or dissociative disorders.
Yeah, under the umbrella of trauma.
Right.
Use.
Right.
With major depression.
see now, I guess when I thought we were pulling off clinical from the other objective that it was in, I thought we were going to be more specific about clinical.
I didn't know that.
Yeah, I know you were part of it last.
Well, I think this is okay. I mean, this is one, and then I think we haven't, I'm sorry, well, we haven't said anything about partial, and we haven't said anything about outpatients.
When I mean specific, that's what I mean. When I mean specific, I wasn't thinking of the specific programming. It's what are you doing clinically that makes our program very unique and that people will want to come to it. Do we put those in the objectives? Some of our scheduling, something, our OT department, and the fact that exists, is that put into here or not? That's what I thought I was hearing you say when you wanted to pull the
Not every
clinical out
psych
of here.
department has an OT department. Yeah, I said not every psych
I thought it was
facility has an
more-
OT department.
How are we treating them? That family therapy would even, well, I don't know.
Yeah, no team.
Something else?
Yeah, family therapy would fit here.
Most
Who doesn't? Northbrook doesn't.
You have an OT department?
Charter doesn't.
OT department?
There is not one OT
Right,
that works at Northbrook,
Activity therapist, yeah.
which is really a therapist.
They do.
They don't even use a consulting at Northbrook. They do use a consulting at Charter, but that should come to an end now that we're licensed, so.
Also from that holistic picture, the multiple disciplinary, even bringing in the spiritual concept, which the pastors, talked to Dr. Altenberg about, and bringing that in. See, those were the things that.
Yeah, Sister Bernarda wants us to really.
Mm-hmm. Is that very
being delivered
Sounds
now?
like it's. It would be good to have some.
Look at, he's scratching at the door. He's scratching at it.
Yes, I think that we need to.
Yeah. For a lot of I think you're talking about strengths of programming really go into the SWOT analysis.
Okay, that's,
So talking about what's great about our clinical programs, we put that in the strengths and
okay.
weaknesses.
So what are you looking for underneath this?
So you're,
I don't know, you're the guys that pulled it out, the clinical piece out last week. I didn't know what you meant when you pulled it out.
It sounds like we want to look at the option of providing a specialty program such as, the adult child
Right.
type program or the multiple personality disorder or whatever that might be.
The notes that from last time we got were, we put under here CQI and ongoing evaluation, The multidisciplinary effort in family therapy/education. So those are some of the beginning.
Yeah, I'm thinking the family therapy that
Should come here that
agree on
number.
at least once per week in each program
Should come here.
We do already have the first objective, the first goal A, we've got to continue to update, review, et cetera, through the quality improvement
Where are we?
programs.
Huh?
And it's very
So you're reading off the different sheets of the same stuff. Yeah. So we don't need to say it again. No.
Either we move it or you're talking about that side.
Or we don't need to have in
It's already covered under A3.
Yeah, I know, I didn't put it there.
Yes.
That's why I didn't.
Why didn't we?
You want to talk about outpatient?
That's a good one.
Yeah. How do you want to?
A little better at Thursday. So,
What?
these.
And these two.
So we'll do integrated
About facility, promoting, receiving
We have to, quantify, put numbers on it, like how many will we try to recruit, how many, and, time slot. I can't just be generic and objective. At least that's supposed to last year now, maybe Cal doesn't care.
two new relationships that will provide 5 inpatient referrals over the next year.
That's the type of,
Is that realistic?
How many patient providers do we have now?
how many outpatient providers do we have now?
That's what we did the last time. We did the number.
1, 2, 3, 4, 5. I mean, we can consider all of the docs as outpatient if we really wanted to. They're outpatient providers, so we have, so it's more. Yeah, so we have all of our docs, and we have Wagner, Harry, Sheets, Krista.
Does it have to be quantitative in terms of the number of providers, or can we quantify in terms of like formalizing the provision of outpatient services by a certain date, where we have an official outpatient department?
Makes sense, yeah, that you have a plan for establishing the plan. And then we can go from there.
Pick a date.
January of '93.
That sounds good. Or second quarter,
And we have to have a tool to evaluate it.
Oh, we don't postpone that.
Earl will say it is. Earl will say it is.
You'll print a phone number, I like that. Dear, calls a good ball.
That's going today, right?
Well, there's some discussion, there will be some discussion about outpatient services Thursday morning, so it's really hard to predict what the outcome will be.
Need a key.
So I think January 93 is certainly reasonable. Okay. Anything else with this? Can we move on to the SWOT exercise? A little bit of time that we had left.
If you help me spell, no one can make one negative comment on this.
Okay, we did adolescent before. we're gonna try and combine the development with Gerald, although there will be some things that are specific to Gerald, specific to Gerald, but we're gonna try and combine, otherwise we're gonna do like all 5 products.
If it
It's
becomes,
really, what I gotta do is to look at what we did last year. Put down whatever thoughts we have about the strengths, weaknesses, threats, and opportunities for each one of the programs now and in the future. Okay. A lot of things a lot of changes. So basically, I guess we're asking you to look at the elements. If there are things we want to leave, we'll leave them. If there are things we want to add, we add them. If things we want to take out, we take them out. We'll go through them real quick. All right? Okay. Sure.
Are we gonna keep it and special care together?
Yeah, I think we're going to try and do that. It's hard to say 364. Easy admission, 24-hour access, leave.
Addition and intake process,
Let's, should we put 24-hour access in?
So I'll develop that one.
Via or through the on-call system?
Yeah.
Which it's not the only way.
Well, that might be right
why don't
under,
we just put in, and then also as an addition one,
Separated.
intake assessment option?
Yeah, because assessment and referral is different from admission. So
Yeah,
for
assessment and
addition to
referral
easy
option.
admission, you might
24-hour on-call assessment referral. 24-hour assessment.
The way you wrote it, it's easy admission with 24-hour access, not within 24 hours. Cross out the end.
Why don't we just write on the board what's not already on?
I was just gonna say, if it's there already, I would rather see you put just next to it, keep, and, because I can do that piece, and just
You're gonna
like
record.
new,
Alright.
like new and different ones added to it, that's
You
what
have
the
one of
reasons
those?
for
Do you
having.
have one of these?
Yes, I do.
Okay, then you right here. Keep on the first one.
That's the system I thought would work out, and then, look over if we're changing some of them or what we're gonna do with others.
All right, so you're gonna keep number 2 too, right?
State-of-the-art equipment.
State-of-the-art equipment, geographic location.
I wonder if the next one is even important anymore. No, the dedicated, remodeled facility with the distinct space and attractive.
I think so, because that's what they remodeled, was to sell it.
Just keep it.
Thank you.
The reason for the next one, dedicated and experienced staff, unique to each program, was to strengthen that Gerald piece, that we do have a dedicated staff on Gerald. So, do you want to change that one or keep it in some form or fashion?
I think that's still the case.
yeah.
Okay. Comprehensive services that are competitively priced. Located in a full-service medical facility.
Yep,
Admitting physicians that are specialized in their field.
yep.
Any to add?
Oh, yeah, no, rephrase this again. You want me to write as far as the 24-hour?
Assessment and referral. With the last one, right, admitting physicians that are specialists in their field, is that something that is unique to our program that other people don't have?
I agree. I mean, we can say truly neuropsychiatrist, functionologist, adolescent psychiatrist. Oh, okay, wrong.
Okay. Any other strengths?
Did you throw
Yeah.
it to us?
Yeah.
All right. There must be more strengths.
We're gonna keep all those we have.
Strong referral development. I think you give yourselves credit here for having what I perceive
That's a good
as
point.
excellent referral development.
Well, and another thing is,
Everybody,
from what I'm hearing from all the other psych facilities in the city, we are one of the only consistent, stable census. I mean, we're,
a good track record and
yeah.
perception.
Well, you're right, strong referral development.
Yeah. Seriously.
Team program.
Referral development program, effort, whatever.
Whatever, which one of the ones?
We take it for granted, but it's.
Strong referral development. Effort, strong referral development team, strong referral development consciousness.
Strong referral development.
Yeah, like effort.
Combines everything.
Cause ongoing. What was that perception in the community that we're a stable program? Is that stable census? I think so, yeah.
Well, we're talking about reputation, right? Reputation in the community. Positive reputation.
Positive community reputation. Positive reputation.
Yeah. But you were just talking about making sure that we put things that we can back up. And right, just facts.
We can back it up.
We
We
continue.
got a lot of
That we can,
Yeah, if you get positive feedback on your survey, that make your contacts.
This probably isn't anything, but I know a solid what's the word I'm looking for? No. This is for some of our referral sources. We've kept a real positive image because we follow through with them. We've kept them in, knowing what's going on with the patients, and the patients have gone back to them.
Good account management or customer service or
Case management.
case management is fine. Yeah, case management.
That's good. Case management and follow-up.
Yeah.
Strong case management and follow-up. Something else we move on to, talking about strengths, we go to weaknesses. Does the first still apply? The first still apply shortage of staff in specialty areas. We're talking nursing staff and clinical staff and shortage of full-time nursing staff. Is that a weakness, Buck?
Then you're running around a pool, right? But and then with pool, down, you don't have consistency, you don't have follow through, you don't have people that are down there, you know where they carry.
Also,
Also, that vested feeling of
yeah, and also that specialty, like, just in general.
Well, actually, it's the whole special needs psychiatry.
Okay, okay.
So we leave that one.
Program develop infancy, we can take out, right?
Well,
I don't think we're new.
Why we say-
last year, we set up the adolescent unit and the geropsych unit. This is last year's.
And the
And
partial.
partial. Yeah.
About program development adolescents.
Yeah.
We're sort of a year into it. We're not on tour, but
How about program development in early stages of program development?
Ongoing program development.
No, can I get rid of that one?
Yeah.
Yeah.
Thanks. 'Cause I crossed it out already.
Here's the weekend admitting.
Procedures need for immediate verification of insurance payments.
Oh, we have Paul.
Paul now, yeah.
Paul doesn't do, Paul won't do the insurance verification. That's still a problem. Like Lucy still indicates it's a problem, not because the hospital can't get the information, but because the insurance companies aren't available.
They aren't there, they just don't.
You know, like a closed sign up.
Yeah.
The only ones that are available are the managed care and or Title 18.
But
Just
what could we possibly do?
Is that a comment on the industry or?
Yeah,
I think more a comment on,
so then, is our problem if it's on the industry? So then, is our weakness making sure that patients are accountable for costs that they incur? Is that our weakness?
well, I remember why this was there. At that point in time, we had a lot of docs, Moy and a couple of other docs who were upset because they come in on Monday morning and the patient was admitted Friday and they don't find out until Monday morning they don't have any insurance. But that hasn't really been that much of an issue over the last 6 months.
but there's nothing we can do.
Yeah, I think you're right.
It's a weakness if there's nothing.
I said 6 months. Check it out.
Is there still problems with weekend admitting procedures? Period.
I don't think so.
So there are no more problems with weekend admitting procedures. I mean, I get after effects, later upstairs, but I don't know. I'm
How
not
about a
in that.
weakness of maybe I don't know, lack of understanding of emergency room, like the relationship of the policies governing admission to our unit with the emergency room. I don't know if that.
6 to 8 months ago, I think it would be so, but I think now it's more,
Now, yeah.
Or just the
Because
case.
Hope Tower has been working with us a lot.
yeah.
I will have to
There's
talk to you
still,
about
it's better. I think we're talking comparative values here.
This is a,
Better,
but I think
there are
it's
still
Nancy's problem.
occasional issues because
I'll let you hear.
We might fit it to an officer, because that's
Same issues. All the same issues.
okay, so we take that one out. I don't know, one psychiatrist for the majority of admissions.
That's,
Who's that called?
Dr. Alford. That's still the case.
Yeah, still. Do you think, the next one, limited acceptance of some in-house medical staff, that's still an issue?
I think it's getting better. It's not completely resolved, but I think it's getting better.
Yeah, I don't think that's as much nearly the issue that it was a year ago. I mean, some people who were actually overtly
Yeah.
antagonistic.
But I think that last CME that we saw quite excellent representation, and they were very, very supportive.
Well, I think just the fact that we've been here for 3 years,
Yeah.
some of those issues have kind of gone away.
I don't know if we can actually come up with an example right now that would support that weakness. I don't know of anybody who sees that as a,
Take it out, I said take it out.
Take it out.
I mean, can anybody hear?
No, that's right.
Because I'm thinking of who would have said
Like
that at one
anything, it's
time.
still, we still can improve on it, but it, from a year ago to now,
Yeah.
it's made a complete turnaround.
Well, that means we have no weaknesses. I just think that's wonderful.
I would say every year.
Staff in our specialty areas, shortage of nursing staff, to be specific.
Would you list weakness, low adolescent census, or periods of low?
Yes.
Well, we're talking about.
Now, this is just
general. and
general and adult.
Oh,
We did the adolescents.
and not partial.
We're gonna do partial.
The adult mental health, is that also including the dual diagnosis program up there?
I believe I have a separate
No.
full diagnosis.
Oh, I've got a separate sheet.
Mhm.
Well, let's go to opportunities and threats, and maybe,
How about from the Horizon Breakfast, the results of that survey that was passed around, the staff themselves perceived the need for better communication? That may be a weakness.
weakness in the morale, internal kinds of petty, things.
Do you want me to write that down?
Petty bullshit.
Petty bullshit,
that's right.
Bullshit is spelled.
Gossip.
What's the B stand for?
I was gonna start.
About internal turmoil,
Yeah.
Better
disorganization.
Yeah.
But
Not just organization.
But I, that's
I
the
would
wrong
have
way.
to say,
Communication.
yeah.
Communication.
We're talking about staff.
She's just gonna get
Opportunities. Opportunities.
Keep that one.
Continued program development, family information night, specialties, support programs, nursing home outreach services, innovative aftercare programs,
Yeah.
home-based assessments by clinical staff.
We have to, wait.
Oh,
We have to redo that. I think.
Which one?
Home-based assessments. I think the first one we can keep, right? That's an ongoing.
Right, okay.
home-based
These are opportunities.
Oh, that's.
is our opportunities. And,
That potentially we're looking at.
right, and, home care has frequently, we've talked about working with them for their own home-based assessments, which would, I mean,
Yeah.
obviously, some of these demand more staff or, a re-setup, but that still is an opportunity, right? Am I looking at that right?
No, absolutely. I think, in fact, I think that's probably more realistic now than it was a year ago, because there's much more talk about home-based assessments and clinical people going into the community. They become part of the outpatient continuum of care.
I do know that Susie Heigman has identified numerous patients,
Sure.
both upstairs out at partial, that could assist in some kind of home evaluation as far as ADLs and self-cares and how they're relating to.
I think that's certainly a more realistic opportunity now than it even was a year ago.
Extend the referral source and the geographic base, recognized as experts in neurooncology and mental health.
Is that more of a strength now?
Yeah,
We developed.
yeah, should we move that over? So we got a lot of strengths.
Would that be under Department of Community Reputation or a separate?
I think it's a separate one.
Yeah.
Well, I think even as long as we're around here, even with the mental illnesses, I mean, if we can start focusing, I know, like with Wagner on his work with manic depressive, on different type of personalities, and even just if we can find that, there's a lot already existing.
Yeah, really become identified as.
Right.
Can I write in specialty areas?
Yeah.
You can, Kelly.
So far,
Specialized areas or specialty area? Specialty, she said specialized. Doesn't matter, it's okay. I got
You know
to.
what it is.
I got to.
Contracts with managed care agencies, certainly that continues. Any other opportunities?
Should we say managed care agencies? Does that encompass HMOs? Or is that two different?
That encompasses?
Okay. That's a lot of opportunities. Let's leave this. Go on to threats.
First one still applies. Second one still applies. Competition.
Speaking of the competition, Norfolk, I know that was a discussion last time you were here. Any official word on?
I talked to someone recently who PI point. Anyway, probably because he wanted Green Bay.
Yeah.
It's interesting, Fox Valley Hospital is ranked number 19 in the state in terms of overall discharges. We ranked number 20. That's the big hospital. Wow.
How big is that?
Valent's doing really well.
Yeah, that's why
The whole hospital site.
Psych.
No, doesn't Valent handle the Brown County, aren't they the county for it?
Well, I think most of the things that were there last year are still there. There has not been a significant change in the status quo in this town,
No.
unlike what some of us thought a year ago that it would shake out this year. Still thinking that it will, but they still have the proprietary hospitals are still there. They're not doing as much advertising as they used to do, but they're still there with fairly significant budgets. It may be less of a threat, but certainly they're there.
I think even though they are, or they continue to be a threat, I think we're holding our own up and above all that.
I agree with you. Yes, you're right.
You know, even over larger budgets and attractive advertising and all that, I think we're holding our own.
And just even with our community work that we've done and with presentations and that we've arranged, we've had wonderful attendance, so.
Okay, is there anything else that we need to do to massage this? Weaknesses, we only ended up with what, two?
Two, we might want to talk about that later, but I have some concern to move on to partial.
Yeah, dual diagnosis.
Anything?
Clean up the room upstairs.
Yeah. So,
Boy, it's getting dirtier and dirtier.
Don't do much.
It's making me anxious every night.
I am getting anxiouser and anxiouser.
You also created a new ordinance.
And where is that card?
I'm prolific. Spending my vocabulary.
we should have it.
It's a hearing, it's a board.
Yeah, it's a board.
It's a board.
We have variisms and now we have orthisms.
Ortisms.
Strengths.
Strong inpatient referral source, that's still good.
Yep, physician's still personally involved.
Although that may change with the move.
Why?
Why?
Well, we can't address that. It still is strong, right? Right?
Sure.
Okay.
We could put it in threat. Yeah.
Yeah.
We can talk about the threat. Mm-hmm.
I think this exemption will be less involved with the move. Because there's nothing unique for it, for them to make sure that it's referring, it would be less and less involved in the decisions for other hospitals. I have to call or I have to do multiple stations in my list if I got to do files and order. So you're saying that each individual doctor will come to see their patient? Well, that's why we're moving. Allegedly, I don't know what will happen, but you know.
That's kind of also an opportunity.
That's also an opportunity,
Sure.
yeah, and that'll also bring in the hospital patient, the hospital. I mean, when I went through in preparing for this marketing plan, when I realized that we have no marketing, no referrals from any marketing source, 2, 4, I think, in the whole tail, that's not healthy either, that we do need to get a good balance from other sources. And until we get that flow mixing, that really, it's a real important piece for the longevity of the partial hospitalization. So right now, we still have a physician personally involved with patients' treatments. Experienced staff with specialized education to enhance the treatment modality. Things change there.
And right now, we still have the next one, but I anticipate that will change. Or the home-like environment.
It wasn't so home.
The hospital,
Do we want to remove that as a
you're not
strength?
describing the hospital as a modern facility?
Well, maybe it's modern, but it's
Are we
certainly not
looking at
home-like.
this as it exists now or the perceived existence after the rules? Is my question.
That's
Yeah, I
a
guess
good question.
Well, I was looking at it in the future, and then Pat directed it back to how it is now.
Yeah.
Allegedly, August.
This plan's supposed to be from September forward. I guess it's how far we moved this.
Well, the move is firm, the time frame is not, but
Yeah.
do not anticipate, we're not anticipating not before August, so we need to probably project ahead, so this is, we presume that it's located here.
Okay.
It's good news, bad news,
So let's change it then, located in a modern facility with access to auxiliary services. Easy access.
But it will also be more of a viable for transportation with the other Trinity van service potentially, I would assume to be involved.
Sure, we'll have,
Now, you would like to change what Christie said?
Now,
Yeah.
with access
Auxiliary
to auxiliary services.
Based on
AUXILLARY. Did I spell it right? I'm excited about
Pretty sad.
you can imagine what happens to her if you give it.
It's not paid,
Clicked off.
transportation would be another strike.
Correct.
Well, it's true, this is on the bus line, and
Yeah.
current partial program is not.
Increased visibility.
For sure. Yep, sure.
Look at your rope hall. Transportation part.
Sort of
Don't let them make you nervous, Paul.
sort of a Star Trek-y thing. It's not high-tech enough to transport the patients.
Kelly was up in Michigan So this weekend, and they call it Star Creek up there.
Really?
Increased visibility.
Do we want to put something on there about the pass procedure? Because that's working out real nicely, even being in Oak Creek. And it gives them, patients, a better idea of what the program's about. And then that will be enhanced even further by the move
Transition from inpatient to outpatient setting.
from inpatient to partial.
Well, it's not necessarily from inpatient, partial, it could be
Pass from anybody.
from anywhere, right?
Well, then it wouldn't be a pass,
No,
though, it'd be an admission.
Visit.
Yeah.
So,
What would be
which one?
transition from inpatient setting?
Ease of transition, yeah.
Easability.
I still like transportation. Yeah, it does.
Comprehensive programming with an effective staff-to-patient ratio.
I changed that to the comprehensive programming with a competitive price. Because I think it's very, just what you have in your strengths into the adult one,
Okay, that's a good.
very competitively priced, because our ratio stinks right now.
Would that improve with the move potentially, with the access of ancillary staff?
Hopefully.
But we can't call it a strength if we're not, if we're saying hopefully, if we're saying, so then I like the competitive price. Comprehensive programming with a competitive, with a competitive price.
It's not priced, it's, is that what you talk about pricing?
Competitive cost. How do we have that other one?
Comprehensive services that are competitively priced.
That are competitively priced.
Sure.
Is that better? Weaknesses?
Do away with number one. I think we still have number two.
Yeah,
Well,
two still.
Yeah,
Is that a
two's still
weakness?
there, although constant, I guess.
Because I anticipate that being probably a problem initially if our census booms, as it is now with an increased census. Patients sometimes don't get to the program until 20 to 10, and we start at 9 o'clock. So if our census gets bigger and bigger, that's more and more people to pick up unless they add a driver.
Any other
additionally, add a
access of
van.
the other van, possibly, from the social service department?
So patient transportation is both a strength and a weakness. It's a really neat marketing thing to be able to say, we'll pick you up, we'll take you home. But
But that
it
is the
certainly
most
becomes,
frequent complaint right now.
but it still becomes a problem in terms of
Yeah.
implementation.
Yeah.
How about the admitting process and the
Are we keeping just constant need for patient transportation? Are we keeping that as that's stated, or is the need for some revising? Leave it the way it is? Difficult admitting process and clearly defined reimbursement policies.
I don't think the admitting process is still difficult, is it?
No, I don't think so at all.
I mean, if you're gonna use it, you're gonna have to charge right
Yeah.
here. So,
Is there anything on that statement that we want to keep?
Reimbursement.
Well, our poorly defined reimbursement policies, we certainly want to keep. They're getting better all the time, but they're certainly still poorly defined.
I think the next one is to do that.
I certainly do.
Right.
we haven't, hasn't been marketed independently.
Are we do we define another weakness as the fact that we only have one doc?
You put that on the adult one, which in terms of the number of admissions, rely heavily on one, dependent on one psychiatrist for majority of admissions. We're not dependent on one for majority of admissions, but as far as overseeing right now. But then if we're projecting with the move, I thought that was the big impetus, is to have them more
Well,
involved.
I think it is. I don't know. It's kind of hard to say what it would like.
Yeah.
That's true.
Yeah.
An opportunity for access to physicians to have access to.
I think staffing is a weakness.
How would we state that?
Coverage.
Well, the opposite of maybe what we have up here, we have effective staff to patient ratio, and right now it's pretty ineffective. And or inefficient.
Availability? It's both.
Where's the cost?
Coverage is an issue.
Well, how about limited staff, availability?
For coverage.
Well, limited staff availability.
Because right now, we still have, Glenn and I are staffing season for the together. Half time, and it just doesn't cut the mustard. With 15 patients on our
Is
roster.
limited staff availability covered, both from a coverage standpoint and from a
Yeah.
limited staff?
Sure. Limited staff ability.
I'm sorry.
Limited staff availability.
Good opportunities?
The one thing under opportunities, that first one, we made it more general in the goals and objectives sections. When we talked about track development, we had initially specified adolescent or AODA or whatever, and we revised that to make it a general statement that we would provide additional tracks of service without committing to what exactly that track would be.
I would like to, if it's okay, to keep these specialized. We have innovative program tracks as the third one there, and that kind of leaves it open for any other ones. But what we keep hearing from the community and the interviews and everything else that I've been involved in, those are some of the main tracks that they're asking for. They really want those. They're really looking at those for outpatient and intensive patient and partial. That's what I'm hearing.
Yeah, we recently met with Waukesha. They're developing, have developed adolescent,
Yeah, it seems like, that's an issue that's not going away, and we can't not to deal with it somewhere directly in this plan here. I see it getting bigger, to tell you the truth, because of the inpatient reimbursement not always being there. I see it getting bigger. So the first one is okay, everybody?
Well, actually, I think development of tracks has to do with housing. I think we're talking about tracks, CKS.
Isn't that funny that that wasn't ever caught? That came through in the marketing plan? But it was right on some of the places and wrong on others. It just,
So instead of that, would you say services?
No, tracks, TREC.
yeah,
KS.
I know that.
Tracks.
I know. It's really odd.
Continued and increased community involvement and integration for the patient. That's still.
Yeah,
What's the
okay.
next one? And then we want to include access to
Yeah.
access to physicians.
Broader physician involvement. Yeah.
Okay,
Easier access.
Opportunity for increased physician.
yes. Increase physician control.
Marketing programs for non-physician sources. So the
That's,
opposite of the weakness. That's what the state has an opportunity.
that's a real, because that's something that we haven't, at least focused on. Marketing to, non-physician referral sources. Marketing to non-physician referral sources.
Moving on.
Yeah.
That's certainly the first one is still there.
So what's the second one?
So it's the third.
And I would add outpatient because that's been an issue too.
Outpatient services becomes a threat.
Inpatient and outpatient insurance.
Burnout. Oh, okay.
Just put inpatient and outpatient insurance.
Oh, okay. I didn't understand. That I see. Yeah, I agree with that. That's not knowing where it's coming from.
Yeah.
Excuse me, how is,
It's not in an overall.
Yeah.
how is the breakdown in physician communication? What do you mean by that?
Communication with doc. They're not talking as well as desired.
Physician means doctor,
So,
communication means talking.
So it's a lack of.
the operative word is, it sucks. Yes.
Well, one of the problems, we know if the doctor's here and getting us out there, or the doctor's in the field.
Right.
You got it.
See, one of the problems has always been that Jerry's the only doc out there. So all the patients that go to him are from somebody else, like the virus or somebody else. If that communication is not greased very well, it's just a big thing.
I have a question. Presently, you just add in Dr. Tiffany, so we can do all admissions and make recommendations as to whether the patients need to be healthy or not. And there are occasions where you and Dr. Tiffany say that one of the doctors or some of the doctor reports are inappropriate at this time. Now that Baltimore and Lilas will be able to see their patients there, will you and Dr. Tiffany still receive all of the admissions? I'm not sure as of yet. Haven't had a chance to go beyond identify that as a real problem and not wanting to become a dumping ground for 5 and 6 different tracks with patients, including MRs, Gero, high functioning, et cetera, et cetera. So I'm not really sure how to solve the problem, but I'm certainly aware that we need to. So I'm interviewing this one though.
This is a no-win situation.
I don't know how to fix
Well,
it.
I think we're going to be looking at the same kind of thing that we currently have on the inpatient side. I mean, do people meet the admission criteria or not, and on an individual basis?
Or a third party will tell you that's not sure.
third party would certainly have something to say.
Well,
Under-
hopefully that will happen, but as of right now, referencing the admitting criteria has not helped. Right. So it that has not mattered right now, so far. And to answer your question from a minute ago, the communication relates distinctly to the very last thread on the page. Yeah, that's the big issue. So, and that's gonna continue to be.
One other threat probably has to do with the influx of partial programs. Every hospital's got a partial program now. So I think a year ago, 2 years ago, when we were the only people thinking about partial, and one of the only partial programs, viable partial programs. Everybody's got one now. And I think this is an opportunity and a threat. Partial is becoming acknowledged as a treatment modality. It's becoming accepted. That's good, but everybody's got one, so that's bad.
So influx of
Increase
increase.
competition.
The hospital must have
Milwaukee started one, Walker Shaw and Mary. Columbia started one, up here starting one before I even went.
Sinai Samaritan,
Sam has one, St. Mike.
Green Bear.
Yeah, I can't.
How many people?
We can do the dual diagnosis, yeah.
Partial,
Really quick.
out of their inpatient. They have to come to the inpatient program. The part of the training and marketing is to develop partial programs. I'm not going to say because
It didn't take place.
they're waiting for a census at hand, so I would say probably 3 months.
Can we go on to AODA real quick?
Okay.
That one to
Sure, as usual.
minimize.
But not
Right.
June 1st was AODA counselor.
And nobody remembered that. I hear
We're not
that.
aware that you're here.
Please don't care.
Well, Harry, you
Yeah.
were recognized in other ways, so.
didn't feel that way.
Just
Been
think.
advertising that thing for a month.
I was gonna say, we gotta review that marketing.
Okay, located in a acute care medical facility which encourage diversification of programs. Yeah. Right, next one, short-term program. Same thing with the next, looks positive. Positive reputation with established referral sources, definitely. And the other one, the last one there, we continue to maintain that.
So all the strengths are still there.
Anything else that after time now with the dual diagnosis service, the acceptance, dual diagnosis as a
You mean in like in the community or
yes, exactly what I mean.
I think it's become more recognized.
When we did this dual diagnosis was
Yeah, they were kind of, but it's more recognized now by the majority of the physicians. I've gotten in-house referrals, and I think it's a strength as far as the marketing we've done in-house here, and how we approach these referrals, these assessments and everything by other physicians, and how we get back to them and things like that. It's become a strength.
So how should we state that?
I give maybe we've already said a positive reputation of established referral sources.
Mm-hmm.
But then you were also pointing out some good case management skills that.
Yeah.
Mm-hmm.
What we'd said for the adult services, case management follow-up.
Yeah.
But those were more specific statements, than just the positive reputation for case management and the referral development, but just.
Yeah, I think that's definitely a
I think they will.
Gary's personal attention to referral sources and that kind of thing.
Strong referral development, say effort. Strong. Good job, Mary.
Or the
And you
week,
thought we forgot
there's
you.
none. Yes.
Absolutely. Timothy doing a great job.
Bob, what about you?
Where are we?
Weaknesses?
Distinct physical placement within the department is still a problem, but I don't think it's as
No,
certainly
no.
a bigger problem as
So I thought it was going to be a heck of a lot more of a problem because I had never worked where we were all combined. But I've noticed it's worked out real well.
That's kind of a weird one.
Yeah.
Yeah.
You know, we
It used to be AODA people used to say, I am an alcoholic, I'm not crazy, and vice versa. But now we see so many similarities between people that have depression and alcoholism and everything. So, yeah,
So you're saying number one we could take out?
yeah, I believe so.
Okay.
All reimbursement.
still an issue.
That's still an issue.
So more of a threat.
I don't know if it's. Oh, well, I don't know. Let's see.
Well, yeah, it's definitely a threat.
Yeah, it's more of a threat than a weakness. It's not our fault.
Yeah,
So we missed the program.
Yeah, I'd report it as a threat.
it's not our lack of understanding.
Yeah.
Reimbursement is the one.
I don't quite understand the next one. Specialized clinical staff responsible for a variety of duties.
The staff, that was actually one that you came up with, that the support staff that you had were now then responsible for,
I have no support staff now.
yeah, well, they were still there when we wrote this
Yeah.
last time.
That's when they were making the transition.
Yeah.
From
Yeah,
That's right.
so, yeah, so that.
Very
So now we want only one, now our weakness is one.
I think we want clinical staff under weakness now.
See, but what has happened is that more and more staff have become sensitized to
Oh,
AODA
yes.
issues.
They've been, and they broadened
And
their,
it's from, so
Mhm.
Thank you, Toby.
Bump it up to strength.
That's because he
Thank
really tells them.
The strength would be that AODA and
all the others.
All the support staff
all
have
the other
become more.
ancillary staff are more sensitive to each other's issues. Sensitivity to dual diagnosis
Mhm.
issue.
They will become more trained in dealing with this more.
So that goes in there.
We have a mobile AODA.
Oh, no. Yeah, me.
How are they gonna get a van?
Get a truck.
Or your car, your Jeep?
So I'm saying that we have now under strength a clinical staff that is sensitive to AODA issues.
Right.
What about the last one here? I mean, are we
That's
seeing?
getting better. That's getting a
I would
lot
say we
better.
see that much improved.
Right, right. There's very few that will slip through. There still are now and then, but it's not like it was a year ago.
That would be my reading.
Do you, so is it a weakness?
I don't think so. Well, I don't know. It may still be.
We still may be weak in that area, but certainly, it's not we're not as weak as we were.
But it's still
I still leave it there.
Should we take low off?
Yeah, but I'd like to have it restated in a way.
Yeah, let's take
Because
low.
Because it's not a low identification.
No, let's take low off. And I'm not sure, let's see, I'm not sure if we don't want to state identification of AODA problems by the community. I see that as a weakness sometimes. Lack of identification of
Is
AODA
it
problems.
identification or acceptance of?
Acceptance.
presence of the
The community's even getting a little bit better, but
Is under identification?
Under
They use it
under identification.
Yeah.
Yeah, we use that under,
We're doing some, but not.
under identification or underutilization.
Both.
But finish that statement. Of AODA problems by other hospital clinical staff. Does that sound right? Under identification?
I would agree with that.
Because we're talking about hospital patients in and that other staff don't
We're talking
identify.
about
That's a real issue
Outside of us.
of us,
all
right?
right, maybe
That's
low
a-
identification or
Under,
under identification of or potential AODA problems in overall hospital patients.
Wouldn't just be patients, it would also.
BC, it's the staff.
I would also include staff, because
Patients and staff.
if you talk, you and I have discussed with staff.
Yeah.
And other. In fact, I think in some ways that's improved.
Well, yeah, it's improved some. Certainly a lot better than it was.
But there's still under.
So basically, we're just saying,
Just keep that
replacing
statement.
low with under.
Yeah, okay,
Okay.
let's do that, yeah.
Okay.
And you could add another one if you want.
Add another one under-
Underutilization.
Underutilization,
Yeah.
under identification and underutilization of AODA services by the community.
Yeah, yeah. Okay. Any other weaknesses? Opportunities? There we go again with family educational night or whatever.
Family programming and
Yeah.
education.
Support groups responding to a variety of addictions. That's another thing.
There's our mobile AODA. I like our fast routes.
Speedy. Drive up
concept. Drive up diagnosis concept.
Drive up what?
A drive-through night.
Drive through, yes.
Drive to diagnostics.
Go to the second window and take.
Alliteration, Italian, and just stick your hand.
So we're keeping
I gotta get one of those.
all the way through.
Better than wave therapy, you know?
What does the mobile AODA treatment team mean?
Fascinating.
I don't know,
Go get you a truck, right?
because I have a truck, yeah. I think Krista came up with that. Just to get back to- I forget what we were thinking about that.
Does it mean,
Assessments.
you know that there is a site out of Milwaukee County, isn't it? They have a mobile unit?
Yeah.
I don't know if that's just AODA or if that's general and if that's just site crisis.
Yeah.
I think we can take that out. I don't, we can't do that.
Now they're slowly anyway.
Keep this next one.
Harry, did that mean, just backing up, did that mean Camden Hospital though, where you would go to the different floors and do assessments? Is that what you meant?
Oh.
I thought it was Mobile, Alabama. I don't know.
I can see our time attention
can we
span
use
has
something
gone
else?
down now.
Mobile?
How about changing
Mobile?
it?
Mobile?
Just the 24, well, that would be actually a straight to 24-hour assessment.
Yeah, that's another thing. Put that down on strength.
Population, absolutely.
We got it for state, so I'll just take it out. I don't know.
We have easy admission for 24-hour access.
Oh, yeah.
I still think having the assessment piece as opposed to just.
Are you putting that under strengths or are you putting that under opportunities? I'm asking really. It's under
I think
strengths.
it's a strength.
Okay.
It's here. How about that idea?
In-house.
The fact that you go to the client.
Oh, yeah, I'm all over.
Yeah, he had his own hearing first.
Yeah. I got my own team, 2 teams. Outpatient.
Very hearing, that's what he called
I think we came in second.
That's part of the contact too with the social service department, the medical social work department.
Yeah,
They're
they've
aware
given
of
me
the
some.
24-hour offering for all this.
That's what I say, when we were talking about the acceptability of AODA services, last year, the first year I was here, everybody wanted to shy away from it. But this past year, it seemed like there have been numerous cases where doctors would call me down or leave a message, come on down and check a patient out. So it's like turned around overnight almost. And it's continuing to get better. It's actually hospital staff to identify potential patients.
That's you taking advantage of that opportunity, and you did it this year. You did it.
Contracts with managed care agencies that's still an opportunity. What about the threats? We're moving reimbursement issues over to
Yes.
threats.
We still have the competition out there. DePaul, yeah. But,
To make sure it's called, not called default.
yeah, default. But I think I don't know, word of mouth from here has gotten around. I mean, and they still have maybe more of a budget to do their marketing and things like that. But I think we're holding our own.
So we still have established competition with aggressive marketing. Is that
Well,
still
competition's
existing?
still out there.
All right.
But I don't see it as much of competition as it was, say, 2 years ago.
Yeah, and because the reimbursement, they won't reimburse them either.
No, that's
And the biggie here is sometimes we run into is with that DePaul and the adolescent issues. When we have adolescents with AODA issues and under some of those contracts, who sends them over to DePaul?
See, what we're fighting is DePaul's record. They've been here for 30, 35 years.
Okay. So we have 2 reimbursement ones here. Reimbursement questions and lack of managed care contracts, and then minimal reimbursement for AODA diagnosis. If we move that other one over. Yeah, thanks, Barb. Thanks a lot.
What was that one?
Thanks, Rob.
We have reimbursement questions and lack of managed care contracts. We have that stated down under threats, and we were going to move over the minimal reimbursement for AODA diagnosis. Sounds like we've got some. Yeah.
And then one lack of mention.
Yeah.
Is that it?
Okay.
Hey. Thanks.
Program that they come in. This is a night education therapy night, and just follow through with that so that they know the time and what the plan